So we're going to be talking about dementia care from the lens of speech-language pathology. So I'm Mackenzie Lind, and I have a background mostly with older adults. I've worked in acute care settings, hospitals, nursing, and now outpatient rehab at OHSU.
And I'm Catherine Paritsky. I'm also a speech-language pathologist, and my experience is also in acute care. That was my final externship for graduate school. Then I worked in a skilled nursing facility in long-term care, and I moved on to outpatient and a little bit of home health, and now I'm in full-time outpatient, all with adults.
All right.
The other button is.
Oh, no. Hold on. We're making sure we can move the pages.
Oh, we're frozen. Let's see. Here we go. Okay. Okay, so today we're going to be talking about a few different domains of speech pathology. So we'll start with our scope of practice, then we'll jump into treating cognitive communication disorders with assessment and treatment options. And at the end, we'll talk about dysphagia assessment and treatment as well. We are going to include all the resources. They're at the end of these slides, so you will have access to all of that information as we go.
We can start with a little quote here. I think it's important for all of us to remember that the need for socialization is the core for human existence. The desire to communicate with others is the essence of socialization. When we think about people with dementia, we have to consider that communication can become a barrier and how that really impacts quality of life. So we should be providing as much support as we can for quality of life. So our scope of practice, so in the US, we do not diagnose dementia, but rather we educate on the disease, we provide appropriate interventions, and we make appropriate recommendations to the patient and care team. So the 5 domains you see are areas we can treat, but with dementia, we primarily work with cognition, communication, language, and dysphagia. So those will be the 3 we're going to really focus on today. So settings that we take a part in, we talked a little bit so in the US, we work from the hospital to palliative end-of-life care. In the acute care setting, just a reminder that it's often more swallowing focused. We want to make sure, because before they leave, are they safe? And then of course, still making sure their wants and needs are met. Then in skilled nursing facilities to outpatient, we are focused on rehabilitation. And then of course, at end of life, we may be a part of the palliative care team.
So we have a pretty broad topic today, dementia. That is a really general term that just gives us an idea that it is a progressive disorder, but it can move in so each person. So today we'll be talking about general dementia, not specifically jumping into treating frontotemporal dementia versus Alzheimer's versus primary progressive aphasia, but keeping in mind that memory and communication are severe enough that they are interfering with daily function. This is a nice summary of how we are approaching our cognitive linguistic therapy and where we can target treatment focus, as well as what we are looking for in assessment. So at the base is energy. If our patients are not sleeping well, if they're in pain, if their stress is really high because of their new dementia diagnosis or things happening in their family, that of course is going to affect their cognition and work across the board into functional tasks, everyday complex planning tasks, as well as some simpler things like being able to focus on a conversation. When we start thinking that we're going to be assessing someone with dementia, we also have to ask ourselves a couple questions, like, can we definitely decide that it is dementia, or is there something else that is causing these cognitive changes? Those two big differential diagnoses are depression and delirium, which we quite frequently see in the geriatric population and especially in hospitals. But I highlighted here some big key points. Dementia is happening months to years in onset. It's not all of a sudden going to appear when they show up in the hospital. It happens over time. And people with dementia are likely to be unaware of their deficits or more likely to hide them. Versus in depression and delirium, the person is most likely aware of what is happening.
Okay, so we're going to dive into assessment for cognitive communication. First thing we should always do is conduct an interview with the patient, of course, and the family, and then the staff, so the care team members who see them most often. When we're talking to the patient, family, and staff, we have to make sure we're getting to know them. Like, what is most functional? What do they care about? What are their strengths and weaknesses? We might pull out a way to rate or stage them with dementia so we can kind of anticipate the progression of the disease. It helps with assessing and treatment. So we'll go over one of these today, which is called the Global Deterioration Scale, but we listed a few others, all of which are free and accessible online. And then at the bottom, we have what we consider screening tests. A lot of people call them assessments, but these do not diagnose technically. These are assessments that give us a baseline, a way to track progress and abilities.
So let's take a closer look at the Global Deterioration Scale, which is one of the ways we can rate or stage a patient's current function. It goes from a scale of 1 through 7, 1 being normal, no deficits, 2 being subjective impairment. The higher in number you go, the more severe the dementia is. As you can see, there is some carryover between stages, but as you go through the stages, more assistance is needed, a higher level of care, and decreased cognitive linguistic function occurs at the same time. This is one of the screeners we frequently see used in the US. So the MoCA, or the Montreal Cognitive Assessment. It's similar to other assessments or screeners like the mini mental status exam, and there are quite a few others that are targeting the same information. This is scored on a scale of 30, as are all other screeners, and they tend to look at the same information, though sometimes they present it a little bit differently. But we're looking at things like alternating attention and problem solving. Can they connect and alternate between numbers and letters and keep track of 2 elements? Are their visual spatial skills intact? Can they draw a clock? How is their naming? How is their delayed recall? How about their auditory attention? And are they oriented? This should be pretty quick, but if this is done with someone who is more progressed in their dementia, this could take up to 30 minutes, which is something to keep in mind if we're trying to get a stronger image of what's happening. I see my screen flipped. Can everybody still see the presentation?
Back on the first slide, the Dementia Care title slide.
Let me try again. It kicked me off. It's very odd. So strange.
One moment, sorry.
Okay. Gotcha.
You could just do,
Yeah.
yeah.
All right, let's try one more time. Share. Okay. Let's give it another try. Okay.
And everything's perfect. Okay. So assessment, a comprehensive assessment for dementia is likely going to be us taking apart different tests because like we're going to have different questions. And time-wise, we might choose one subtest from one exam and one from another. If we are just specifically looking for things like language, we might look at the cookie theft, which we'll look at in a moment. If we're wondering about naming, we might pull out something like what we call the Boston naming test, which is, what is this? Clock, and see how many they can get. So if we are following a patient over time though, again, just a reminder to use the same measures across the board. So for example, let's say we pulled the clock drawing test, which was from the MOCA, which Catherine showed us. This actually gives us a lot of information across the domains with one simple, easy, less than a couple minutes activity. So the clock drawing is us, usually we provide the circle, like there's the circle already drawn. And then we give instructions. Please put all the numbers in the clock and set the hands to 10 after 11. What we can see is as the disease progresses, there's more errors and organizational issues. So in the early stages, all the numbers are there and like the sequencing is correct, but the hands, like the details are not quite right. And then as the disease progresses, we see that, maybe their attention strayed and they all of a sudden didn't realize they were outside that circle border. And then the last one, we actually noticed too, the numbers, hard to read. Maybe there's some motor deficits happening, and maybe they didn't even hear that they're supposed to draw the hands. Okay, another example. So if we're looking for a language sample, we might pull out a picture. This is one we use, it's called the cookie theft. We set it down in front of the patient and we say, tell me, what do you see in this photo? We don't do much prompting. We just kind of want to see what they're able to generate on their own. We try to see, are they using single words, whole phrases? How much detail are they using?
Take a second and think about how you would describe this picture. It might be something like the man is washing the dishes and the sink is overflowing. And the little kids are stealing cookies behind him, and the dog's eating the cookies that fell on the floor. Most likely, you'd be using full sentences and be able to identify the different elements of the picture. Things we're looking for when we're assessing the language abilities. Perseverations, so is the patient repeating the information? For example, if we showed them an image of a boat on the ocean, they might say, I went deep sea fishing before, and then tell you the same thing 5 minutes later without any recognition of that. We're looking for paraphasias or associated words. This could be associated by meaning, like saying dolphin instead of fish, or associated by sound, fit instead of fish. There might be nonsense words, completely made up, that are not related to the target. The patient might also be able to describe what they're looking at, but be using increased words and verbosity to cover up for the fact that they can't exactly reach that pinpoint target. So instead of calling something a fish, they might say, oh, it's the animal that swims in the ocean, and giving you a vague description. There might be grammatical errors where they're putting words in the wrong order. And again, this increased description. It was swimming in the deep blue and it was so dark and it got lost, but you never get that exact answer you were looking for. We might also see communication breakdowns where the patient starts on the correct path, but then they lose either the word they were looking for or attention and don't make an attempt to fix that. So here are two examples of different diagnoses describing the cookie theft. The aphasia profile on the right is somebody who had a stroke, and on the left, progressive aphasia, which is a form of dementia. You can see that there are some similarities. Janice out doing the outside stuff. There's a man washing dishes. On the other side of the aphasia, the dishwasher. No, the dishes are pouring out on the floor. There are errors in both of these, and while the aphasia profile is shorter, it's also much more concise, versus the dementia profile jumps around quite a bit, and there are a lot of these unfinished ideas.
Okay, we are diving into treatment now for cognitive communication. So we kind of kept it the same color code, showing you that this is taken again from that global deterioration scale. So we're going to be referring back to that a bit with the stages. So again, stage 1, no treatment, but we notice stages 2 to 3, 3 to 4. These are more mild and moderate impairments where we can still have treatment be a little focused on restoring. And then we add in compensatory strategies. And then later on in the severity of progression becomes more maintenance and training staff on ways to manage breakdowns, behaviors, swallowing issues. So obviously we can actually predict with this that, if we know someone's in stage 5, we might prepare them for what's to come in stage 6 and 7.
Before we start assessing and treating patients, we should also be making sure that the patient is set up to succeed in the task and that we ourselves are as well. What does that mean? Making sure that the patient can access information visually. Can they hear it? Are their hearing aids in? Are their glasses on? Do they have water? Did they go to the bathroom? Those are all going to detract from their attention as we are working with the patient. And then are we set up? Are we calm? Are we focused on the patient? Are we at their eye level and able to create this face-to-face communication? And are we ready with what we need? Is the environment set up? Is the lighting good? Is there a lot of background noise going on? Is it busy? How can we limit those things? Is there a lot of visual clutter where the patient might begin reaching for things that we're not attending to in the moment? There are also general communication tips that we can use with people with dementia or any other kind of cognitive communication disorder. And it's always good to keep in mind that we're speaking slowly, giving extra time to take in information and respond. This can feel unnatural, especially when we're used to this quick back and forth, but that doesn't give the patient with dementia room for success. It's going to feel strange to sit there and wait 5 seconds or 10 seconds in silence for somebody to respond, but ultimately we want to hear what they have to say. We can also use different forms of communication. It's not just verbal. Can we add pictures? Can we write what we're saying? Can we add gestures? Another thing to keep in mind is how we're asking questions. People with dementia have difficulty answering open-ended questions and benefit from choices. So for example, instead of asking, what do you want for dinner? You could give them a choice. Do you want chicken or fish for dinner? That way it's closed and they don't now have to sort through all the possible options in their heads. So let's try an activity. I want everybody to imagine that they're presenting 3 activity options to a patient. They can either go for a walk, they can help make lunch, or they can watch a movie. How would you pose this question to the patient so that they could successfully participate and answer? I'll give you guys a couple seconds, and then if I have any volunteers, feel free to share what your response would be. Is anyone feeling brave and want to share? So this is what I would phrase. Hopefully I would know my patient's preferences and perhaps know they have no interest in making lunch. But I could present them with a couple options and say, we have some activities this afternoon. Would you like to go for a walk? Let them yes or no. How about making lunch? Yes or no. Would you like to watch a movie? It's an old classic. I think you're gonna like it. Perhaps they say yes. We can also support this by providing pictures, using calendars, so that way the patient has, again, different ways of intaking the information and responding differently if they need to. The final thing to remember, which is pulling off that video that we sent, the YouTube video with using improvisation, is going along with the patient's reality. The purpose of us as speech therapists is not to impose our ideas of what is correct and incorrect to the patient. The point is to keep them independent and participating in their daily environment. So going along with their conversational choice and going along with what they say. For example, look at that nice, cute black cat in the corner.
That is, oh, look at that cat. I wonder where it's going.
I don't know, maybe it's hungry.
Maybe.
There's no black cat in my office, but that's okay. The point is reaffirming what the patient is experiencing. It takes some practice to be so fluid, but it's learning to roll with the punches and go with the flow, and that's really important as far as working with people who have dementia. If it's going to kick me off again, no.
Okay. In the early stages of dementia, we can still facilitate some level of restoration because we know with the brain that we can still build neural pathways. So restoring function, educating, and collaborating with the family and care team is really crucial here to also set them up for success in the long run. The way we can restore function in someone with a cognitive impairment is through what we call systematic instruction. It's this idea that we're giving them ample practice of a skill, that we're giving them the right cues at the right time over a course of not days, but weeks, months, and of course it should be functional, and so they will also be actively engaged. We'll talk about two of these types of instruction today, spaced retrieval and errorless learning.
Spaced retrieval is a method of teaching a multi-step process, a functional one. So something somebody would do on a regular basis, like making a phone call, remembering to say goodbye when somebody leaves, or not forgetting to hang up their phone after a call. These are all multi-step tasks that require consistency. So before we decide to use spaced retrieval in our treatments, we have to make sure that the patient is actually a good candidate for it. So we use this screening process. So me and Mackenzie will demonstrate, and I'm showing her a picture of a person. Mackenzie, this is Bob. Who is this? Bob. Right, Mackenzie. I'm gonna ask you again in a couple seconds. Try to remember his name. And in 10 seconds, I'm gonna ask again, and hopefully Mackenzie is going to hold on to that information. All right, Mackenzie, look at this person here. Do you remember their name?
Was it Jim?
Not quite. This is Bob. What's his name?
Bob.
Good. So we returned to step one because the first trial was successful. The first answer was incorrect. So I had to return to the immediate presentation. We'll try again. What's this person's name?
Bob.
Great. Hold on to it, so I'll ask one more time. And we would repeat the same exact process after 15 to 20 seconds. Last time, Mackenzie, what's this person's name?
Bob.
Great job. This is Bob. Yes.
Okay, so errorless learning kind of goes hand in hand with spaced retrieval. They take concepts from one another. With errorless learning, it's the principle that we are giving ample modeling, providing specific patient-centered cues that are concrete and shape the response we want, and fade them out over time to give the patient with dementia more independence. And we call this vanishing cues. If there is an error, that's where the errorless learning comes in. We should provide immediate feedback and remodel the response we would like, similar to spaced retrieval. We are minimizing guessing, and all the while we're still making sure that they're engaged fully and that we're not, again, doing this in one day, but over the course of a treatment plan. We won't take a look at it right now, but I provided a video example of someone demonstrating how to give vanishing cues for a walker sequence. The gentleman, he basically says, okay, you know how to do this. I'm gonna take back some of my cues that I was giving you and see how you do. And he grades them accordingly and provides more shaping and modeling as needed. So with errorless learning, we may have a patient. So here's an example. They are not washing their hands. We would first want to see what's going on. Maybe they're looking at the sink, but they're not quite engaging with it. So perhaps we bring them up to the sink and we say with them, what is this? And they say sink. What do we do with the sink? We hope that the response would be, wash my hands. Next day, I might come to them and say, oh, what is this? And hope that they will automatically say sink. And then if it's incorrect, I would bring them back to the actual sink and say, this is a sink. What do we do in the sink? We wash our hands. And then slowly again, fade back the cues until they're successful. That we hear from staff, oh, a patient, they're washing their hands 2 times a day instead of 0. And that's successful.
Moving on to the middle stages of dementia progression, our focus shifts. We start compensating more, giving strategies to onboard. We're moving more into care partner training. So is that family, staff, maybe friends that the patient spends time with frequently, and making sure that environmental modifications are in place so that these routines are already established before the patient moves into the more severe of the disease. These strategies include external aids, identifying activities that the patient wants to continue to participate in, establishing routines, and using techniques such as priming, Montessori, and reminiscent activities, which we will explain as we continue through these slides. This is a very quick summary of compensatory strategies that we commonly use. Most of the time we're looking at memory, attention, and communication or word finding, as these are the most frequent complaints and why we're getting patients referred to us. I won't go into every single one for the sake of time, but things like making sure we're writing down information. Are we creating external associations and links so that that new information has another connection that already exists? Working on names of important people, loved ones, staff, and in these strategies, we continue to use spaced retrieval and errorless learning. Learning to manage distractions, reducing multitasking and doing one thing at a time. We really emphasize continuing to socialize. The general action when people are having trouble word finding is to withdraw, but that makes it even more difficult because then they don't have that practice and it makes it all the worse when you're not socializing and getting that information quickly and having to respond. We also really work on reducing the stress around word finding and being okay with the fact that once in a while that word might escape you, but usually there's enough context and communication that the person listening knows exactly what they're talking about. So let's jump into priming and sensory stimulation. These are both ways to get the system, the brain and the body, ready, awake for tasks in a non-demanding way. So for example, we might have a patient reminisce or talk about their past 20 minutes before a meal so that they can be more engaged in mealtime with less cueing from staff or family. Or maybe it's having a snack 30 minutes before a visitor comes, so when their family member comes, they're not still in bed and waking up. We do this all the time for ourselves. Most of us don't wake up and immediately switch into work mode. We get dressed, we brush our teeth, we drink coffee and have breakfast. That's all priming. We should remember that that is a natural progression of most people's days. So it's difficult if somebody is in someplace like a nursing facility where maybe they don't have that independence and most of their time is in their room. Well, now we need something to kind of wake them up a little bit before we start putting these increased demands on them. Sensory stimulation is the exact idea as priming, but we're focusing more on the senses. So touch, smell, sound. Can we listen to some favorite music, look through memory books or old photos, maybe playing a game or being around meal preparation? There's lots of options.
So reminiscent therapy is a form of priming and sensory engagement. The purpose of it is to increase language output, to increase participation, and this is a great way to decrease behaviors like someone wandering or yelling out. It involves very low tech, so find things in their natural environment, things that they already enjoy using, or gathering materials as we need them. Again, they should be relevant to the patient. So things that evoke strong memories like photos, music, movies. They should engage multiple senses. So not just sound, but sight. We can create toolboxes, and I'll show you some examples. We could theme these boxes, like with holidays, weather, the person's interests, so that if we know one patient who's displaying behaviors, likes gardening, we'll go grab the gardening box and we won't have all this material that will confuse them. When we pull out a toolbox, let's say Kathy is looking at the box and she is not super engaged yet. She's looking at the material, but she's not saying anything. I could say things like, ooh, I wonder, this reminds me of. I'm not asking her questions that are too demanding, but rather inviting her to participate with me. And a reminder with all of dementia care that more time for them to respond is always best. Being okay with some silence. Yeah, so here's some pictures of some toolboxes that we actually made at Pacific University ourselves. On the left, we have our gardening box. On the right, we have the cooking box. So we may have some of the materials laid out, maybe some are still in the box, and we would invite the patient. Let's say Kathy, she's picking up the gloves. We pick up the other glove and we feel the glove, and we invite her to feel the gloves, put on the hat, touch the flowers. And then let's say we open up one of those magazines, the gardening magazines. There's a picture of this yard. Let's take about 20 seconds and just think about how we might approach setting up a conversation or reminisce for someone with dementia. All right, let's say Kathy's my patient. She's looking at the picture, but she's not saying anything yet. And let's say it's been a couple minutes. I wonder who's going to pick up all those leaves.
It's not gonna be me.
Me neither. I used to have a lot of leaves, just like that.
Just let the wind blow it into the neighbor's yard. Not my problem.
Now we have this social exchange going. We'll keep on. Okay.
Switching over to Montessori-based activities, pretty similar in purpose to reminiscence. These are not necessarily approaches that we're using for remediation or fixing. This is for providing an opportunity for socializing and participating so that the patients feel independent and dignified. With Montessori activities, we're picking tasks that have a clear purpose and end. They don't require any kind of reading, and there's no one correct way of doing it. Again, working with the patient's expectations and their reality. We can pick functional tasks like folding clothes or sorting objects. We can invite the person to join us, but perhaps they won't want to. So we can just sit next to them and slowly move through the task, and the person will eventually join or show interest, and we can share with them. Montessori can be done in groups, it can be done individually, but we have to make sure that we are keeping with the pace of the people we are working with and not our own pace. So here are some examples of Montessori activities: block sorting, gardening, puzzles, folding and sorting laundry, and sensory aprons that the patients can actually wear. We have a quick example what kind of activities in this link. It's a pretty long video, but if you click this, it will pin you to the spot where they start showing different kinds of activities.
In the late stages for cognition and communication, we are involving the care partners even more. We're teaching them what we have provided as our treatment so that it's consistent across the caregivers. They shouldn't be guests anymore. It should be everyone working as a team. So we're educating on the disease itself, answering questions that they have about it, about strategies, types of cues, and what modifications we may provide. So what we have taught you all today with reminiscent therapy, Montessori, and sensory stimulation, these are things we can teach staff, family, and strategies may be more specific depending on the patient, like handling repetitive questions, saying, oh, we can handle that by reminiscing, or spaced retrieval to answer that question. Managing behaviors. Maybe we engage someone in a Montessori activity 30 minutes before the evening time when we know the patient is going to wander. Communication strategies. We have a link, and we'll talk about it in the next slide, but something called focused. And we can teach them ways to verbally and non-verbally communicate appropriately, like yes, no questions and pictures.
What is focused? Focused is an acronym for keeping in mind the strategies that will allow for successful communication with the person. So, is it functional? Are we actually facing each other? That's going to make a huge difference with receptive communication and understanding. Can we establish the topic? Let's talk about dinner tonight. Can we make sure we're staying on topic and giving concrete information? For dinner tonight, I think we're gonna make some pasta. Can we unstick any blocks? Communication blocks. So those moments where things start to fall apart, can we just provide some support to the person so they continue to feel like they can share what they want to? This can look like pictures again, writing, letting the person point and make their choices. Creating the ideal structure with choices and yes or no questions. Making sure we're allowing for an exchange of information, an interaction, not just one person giving information to the other. And direct in short sentences.
Environmental modifications are important to decrease confusion, decrease behaviors, make the environment more welcoming. I won't go through each one individually, but we might have orientation aids like calendars, blocks, daily schedules. Environmental specifically might be opening the blinds and letting in natural light. We might have reduced clutter, as mentioned earlier. We'll talk a bit more about this, but calm and contrasting colors help with vision impairments and confusion, keeping less distractions. For memory books are a great way to engage. It can be an activity with the patient. We might have visual reminders for them on what their day looks like, write down the schedule for the day on a whiteboard. Here are some examples of visual aids we might use. Notice how they're quite contrasted in color. I would even, maybe with the one on the left, that sign that has the stop sign and the walker, I'd probably include a nice strong border so that it's hard to miss. So when they're getting up from bed, they see that stop sign and look and then know that, oh, before I stand up, I need to use my walker. So they don't even need that text perhaps to know what to do. With the shower and the bathroom and toileting, again, there are symbols. So in case literacy is no longer a strength, they have those images to direct them to the right location. And then clocks, we might decide if a person has, if it's easier for them to read a digital versus an analog clock.
I'm gonna pause here for a second. Connie, I see there's some questions popping up. Do you want us to stop here before we move into dysphagia treatment, or should we run through the end and do questions at the end?
I think you should answer these first.
Okay.
Does that sound okay to you guys?
Absolutely. Let's see. Let me exit the screen view in the chat. Okay. Cameras. Okay. Questions. Okay, so the first question I see is the unique feature of Montessori, is it a contrast activity? I think I know what you're asking, how different it is from reminiscence. I would say it is different because it is more about an action and completing the action versus reminiscence is more about sharing an experience that the patient might have had at some point. And let me know if I didn't answer that question correctly.
We will be sharing quite a few resources at the end of the presentation for benefits of dementia care. And then I see a question, during the treatment visit, should we include family caregivers to stay? Any pros? More pros than cons, absolutely. They are the biggest communication partners for these people. They should be seeing how we're engaging with the patient to give them feedback and advice, and also give them positives. Like, I think how you're talking to your mom is great. Keep doing that. The only time we should be doing things individually is if we're doing perhaps spaced retrieval, and if the family is too distracting, for instance. But family, more the merrier. Include them at all costs. Kathy, let's see.
A part of assessment by a patient looking at the picture and explaining the story. So with the cookie theft, most of the time we're using it verbally where the person is saying what they see. But if writing is a preferred form of communication for them, I would absolutely provide them with a piece of paper and a pen so they can write, because that might be a strength for them and we want to know that. In each response. I'm not sure about the question for response, how different for diagnosis. If you could clarify on that one. How long should each session be? Yeah.
Let's address the time question.
Yeah, so our sessions are usually 45 minutes. When I was working in nursing facilities, they could be anywhere from 15 minutes to an hour. It really depended on what we were trying to achieve. If it was something like a reminiscent activity to prime the patient for a meal, that could only take 15 to 20 minutes. I don't need to do that for an hour. But if it is someone earlier in the phases of dementia, or we're doing a lot of caregiver training, it might be an hour. So it's really based on the patient's needs. It depends, what we're working on. But I would say the norm is usually about 40 minutes for us. Yeah.
Okay. And early detection. We might be able to answer this a little later on, but at the end, if the question is still there, we can definitely address it.
It's the early detection.
Early detection, yeah.
Preventative rehab. To recommend to that person.
Let's see. Oh, I mean,
Genetic testing. I can say informally, there are patients getting genetic testing. It's a lot of the times it's after the fact that people are starting to show symptoms. Same goes for brain scans. They are just after the fact. I know here we're not really using it as a preventative measure just because of the expense of it. It would be great if we could, but unfortunately we can't. And so that's where those things like the screening tests are coming into play, because most doctors who are working with the aging population are giving some kind of screener like that to see if there is a progressive change over time, because we would expect that there is not in normal aging. So with the talking and writing, can it show the differential diagnosis after the?
Yes, we know that talking and writing, I mean, both expressive, but it just depends on the strengths. Some people, the writing, the motor skill brings back that language ability, that language center gets stimulated when they have that physical tactile stimulation with the pen. With the cookie theft, you could definitely include a writing sample at the end. Just make sure that the bulk of it is the verbal part.
And if we're thinking about differential diagnosis of different types of dementia or maybe other disorders, absolutely, right? If we're thinking maybe it's something more like Parkinson's, right? And you give them writing and all of a sudden you see they have an intention tremor, right? Well, that isn't a very common side effect of dementia, right? Dementia is very much, especially in Alzheimer's, is very much a language-based process, right? So what we're seeing kind of go first and why they're being referred to us is usually a good indicator of where we think it's going. Okay. All right. So we'll move on to our next section, swallowing. Let me share the screen. Let's do that. So, perhaps not exactly perfect ways to preventing dementia, but to slowing its progress overall and the appearance of initial symptoms, and this goes for everybody, is being mindful of this overarching term, brain health. So what does that mean? Making sure that many systems in the body are working the way they should be. So, is the patient sleeping well? Are they exercising? How is their heart health? If your blood isn't pumping well, of course it's going to affect how your brain is working. How is their diet? Are they making healthy choices when they eat that support brain and body function? And two other things that we often forget are socializing, making those connections with people. We are social creatures and we need to talk to other people. That doesn't mean we have to be going to group classes all the time, but even making a phone call or sharing a meal with somebody. It's very important. And if we think about socialization, that quick intake of information and having to create your own thought about it and respond, that takes a lot of work. The other thing is engaging our brain. That doesn't mean the patient needs a new hobby every week, but can they do something that they enjoy and is varied and maybe makes them think a little bit differently from the day-to-day type of tasks. All right, so moving on to dysphagia, swallowing disorders. We have to remember with dysphagia that this is also very cognition-based. Sight, smell, touch, sound, and taste, they all influence the food of choice and the memory of pleasant experiences. How important is eating to you? Sharing a meal with your family, being able to sit there and enjoy what you're eating. For most of us, that is a huge piece of quality of life. Maybe we don't get to have huge family dinner. Appreciate the moments when it's every couple of months. And this applies to everybody across the lifespan. So what happens when all of a sudden that is forced to change? It's usually a decrease in quality of life. So quite like communication, we have to consider the stage of the disease to establish what is appropriate. Cognition is going to affect eating and swallowing. So we're really working on prevention here again. Are we keeping them safe? Do we have to change the environment to keep the person safe? How much physical support do they need? Is it because they cannot access the food or they can't sit upright that's causing these swallowing difficulties?
With picking out assessments, much like a cognitive communication assessment, we should start with an interview. Get to know the patient's natural eating environment. Are they eating 3 meals a day? Do they tend to eat 2 meals and lots of snacks? Are they someone who has behaviors at meals? And then we might give the patient a self-rating form. Questions like, how often do you cough during a meal? Those look like the EAT 10 and the Promise Swallowing. Those are available on the internet for free. Clinical assessments. These are bedside swallow evaluations where we are taking a clinical look at how they're doing with certain textures and liquids. We may give them what we call the 3-ounce water protocol, which is giving them 3 ounces of water and seeing how they do. There are some more objective measures that test the cough strength and some tests that look at the chewing abilities of an individual. We'll take a look at one called the TOMAS, the test of mastication and swallowing of solids. If we are worried about aspiration, foods going into the lungs, we then make sure we're doing an instrumental and visualization study. These are typically done in the hospital. In the US, we have mobile fees. I'm not sure about in Thailand, but these take a look at things we cannot see with our eyes. And so instrumental is really important, and we'll talk about why, but we should not be downgrading textures unless it is absolutely necessary.
Okay, so I'll quickly go over the TOMAS. To use this protocol, all you need are some saltines, water, and a stopwatch. You give the patient cracker, you tell them eat this as quickly as possible, and when you finished, tell me your name. You're tracking how many bites, how long it's taking overall, and how many swallows they're taking per whole cracker. So you have to be able to have a clear line of vision with the patient. Ideally, you're not touching or palpating because that will interrupt the naturalness of the process of eating and swallowing. However, depending on the patient, that might be required if you don't have a good visual, perhaps because of their weight. You can do a second trial if they did well with the first trial. However, we're only using the data from the first trial. And we have the norms included in the resources there at the end. This is just a snippet of a bedside swallow exam. that we would use. Again, we have this in the resources, but we're looking at different levels of liquids, so thin, any level of thickened, and what kind of food consistencies. Let's say I'm asked to evaluate a patient who is on a level 4 pureed diet with slightly thick liquids. Yes, I would go in with pureed, but I would also go in with a level up or maybe 2 levels up, because I want to see what they're able to do when there's somebody there cueing them, making sure they're safe, and ideally upgrading them instead of downgrading them more. Sometimes it's just a simple fix that will allow the patient for a larger range of consistencies. This is a great chart for considering the risk of pneumonia. So we often talk about aspiration, but there are lots of people who aspirate without ever getting pneumonia. So we have to consider, what are these other factors happening that are causing certain people to get pneumonia? You can see here, there are quite a few combinations, but the only one that results in pneumonia is the combination of all three: compromised immune system, unhealthy oral status, and laryngeal aspiration. Otherwise, we're not getting pneumonia, and in that case, we should ask our question, should we actually be changing their diet?
Informally, when we're observing mealtime, we should be seeing them in their natural setting. So if they typically eat in the dining room, we should be seeing them eat in the dining room. Seeing how they interact with people at the table as well. If they normally sit with the same group, let's make sure we're setting it up the same way. And we may provide limited intervention, but typically we scale back quite a bit to see how independent they are. Things we're looking for is, how is their positioning? Are they close to the table, far away, at the table's level, or too high, too low? Are they initiating? How much cueing do they need? Are they accessing the food okay? How big are their bites and sips? Is there oral residue? If there is, are they clearing it on their own? Do they need someone to tell them to take a swab and look inside their mouth and pull it out? Are there behaviors present? Are they distracted? And then, of course, we would note if they are coughing and what they're eating that is causing the cough. So we talked about priming earlier. We can use priming with mealtime. We can prime before a meal to improve their participation with eating. We can increase their initiation and decrease behaviors. So we can modify the environment as well. We might change the way the food is presented. The thing with presentation is we have to consider the senses. If vision is reduced and we have a white plate on a white table, that can be really hard to see. So maybe we put colorful place settings down. And maybe it's easier for them to have separate bowls of different foods to make it clear when there is one food versus the other and when they have started and finished. The kind of environment is also important, noticing if they respond well to if it's busier versus more quiet. And then we'll talk about diet modifications. We use the framework called International Dysphagia Diet and Standardization Initiative. And so this is global wide, and we actually included some resources at the end. Okay. For time's sake, I'll just quickly say this could be an activity you could do on your own. Looking at this, what might you change? And then if we look at the next slides, we might see that huge change in environment and how we set things up. Notice all the colors, the different kinds of placemats and napkins, how the silverware is presented. This might make people not just interact with the food more, but actually eat more.
We should also be wary of other things on the table that are not edible, because I've seen quite a few patients try to eat the centerpieces on the table that are not edible. So we want to make sure we're providing a safe environment for all of our patients. So, easy fixes, but very important things as far as dysphagia goes is maintaining safe positioning. Is the patient upright? Maybe we can put them in a chair instead of having them in bed. I think for most of us, eating in bed is not at all a natural thing, and that's going to potentially stop somebody from being as effective in their eating and being safe. Are they close to the table? If they're in a wheelchair, can we lock the wheelchair so they're not rolling away while they're eating and trying to get to their utensils? And oral care, like we saw on the chart, it's one of those pieces in preventing pneumonia. So making sure we're using a toothbrush and toothpaste multiple times a day. If the patient has dentures, we're cleaning them and maintaining is on board with this and doing this consistently, and it is not just the speech therapist doing this. So what is good oral care? We've got a nice summary here. So brushing, moisturizing, and again, making sure those dentures are clean and maintained.
Here's a clear and concise image of how the IDSI framework works. It is the same, again, across the globe, and they are translated. So we included the Thai translated IDSI framework in the resources. Notice how the food on the left, the foods on the left, notice how number 7 is, oh, thank you. Oh, you have it, yes, awesome, great. So we're gonna skim this, love it, love to hear it, because I mean, in my facilities I've been in, not everyone has been rolling, and it's frustrating and challenging when we don't have the same terminology. So
it's like speaking 2 languages with the same thing. Yeah. But we love IDSI.
So of course, diet modifications, right? We have to make sure when we are changing it, we have to weigh the pros and the cons. Whenever we're downgrading foods and especially liquids, we should be doing those instrumentals. We have to think about how much of a risk malnutrition is or dehydration if we are downgrading. We have to remember that even with chronic aspiration and no pneumonia, we should not, it doesn't always occur. And so we might not have to do a diet change.
So, last piece of treating, again, care partner training, making the family and the friends and the care staff part of this process so they understand why and how. We only see the patient maybe once a week. Even if it's every other day, we're not going to be seeing them forever, every other day, and we need to empower other people to be able to do this and provide safety and quality for the person we're working with. I left this alternative feeding at the bottom because we sent you some articles about this. In the US, there has been a practice of using tubes, any kind of alternative feeding when the person is not eating. However, there's no evidence to support that this actually helps quality of life in patients with dementia. Of course, there's a time and place for alternative feedings in other populations, but ultimately with dementia, it is not an advised process. Even if we give them an alternative feeding, aspiration can still continue on their own secretions and on the tube feedings themselves as well, depending on the source of the dysphagia.
Mm-hmm. This is an example of a diet slip that we might fill out if we are making diet changes. We would put the current diet order, new diet order, and I think what we just want to emphasize is we should take into account what the patient wants. If they are saying no to thickened liquids or downgraded textures, we should still put new diet order then. Okay, we're going to put down what they would like, but then in parentheses, perhaps we put needs one-to-one assistance. We're trying to create accessibility and promote nutrition as best as we can.
So last piece of the puzzle, thickened liquids. I personally avoid thickened liquids as much as possible. If I ever have a patient on thickened liquids, my goal is to get them off. Why, you might ask? There's still health risks with it. it increases the cost of care, and it reduces the quality of life. I feel pretty confident in saying nobody in this meeting wants to drink thickened liquids. They can lead to dehydration. They can lead to a feeling of increased fullness, so the patient is less likely to drink, and they might just avoid it because they don't like it. And pneumonia and respiratory complications can still pop up, and they actually have been shown to increase with the use of thickened liquids. So what are the alternatives if we're not going to thicken the liquids? Well, maybe we can try something else before we go down that route. Can we do a swallowing exercise programs, especially in the earlier phases of cognitive changes? Or can we have maneuvers put into place? Things like a chin tuck or an effortful swallow. If thin liquids are causing aspiration, maybe some sensory changes will make a difference. There have been some studies shown that trying hot or very cold drinks can help, as well as carbonation, because the increased sensory input slows the swallow ever so slightly. Or can we use a free water protocol where they're not drinking water during mealtime, but between meals and after sufficient oral care, they can have water. We've included a reference on how to use this protocol as well. Why not diet modifications with thickened liquids? Well, if the patient has any other underlying disorders like dehydration, renal failure, reflux, this will cause an even further decline, and they might also interfere with medications. So
we are at the end. Okay, so we talked about the cognitive communication and swallowing aspect of dementia, reminding ourselves it's complex, it's very individualized, it varies from person to person, but using the global deterioration scale, we can set up some predictions and make appropriate assessments and treatments. As clinicians, we have to look at the patient on a holistic level, get to know what they like, what they don't like, make things as functional as possible to also not just help them with their quality of life, but decrease the burdening on their care partners. So by figuring out the stages that they're in, what the appropriate treatments are, what makes sense for them, we can improve quality of life. Last note, right, we must work as a team across disciplines. Our own communication matters to help with communication within dementia. All right.
All right, we've got questions. We left our contact information, and just to show everybody, we have the resources shared for separate for dysphagia, and then with references. So if anybody's interested in more reading, this is where you'll want to go.
You can share even more if you would like.
Yeah,
we got a lot.
We didn't want to overwhelm you. I'll stop sharing.
Thank you so much. Amazing, amazing presentation. On the brain health slide, you also have a reference there on brain health for preventing. That is wonderful. And there's one question I don't know if you guys have any thoughts about. Do you think oxygen during exercise help cognition at all? Have you ever had any research or discussion of benefiting the patient's performance impairment?
You know, not supplemental oxygen, but I've seen significant improvements of just reminding people to breathe more deeply when there's stress on someone, when there's a high level of demand. If they are just taught to breathe maybe through the diaphragm, right, that decreases kind of that overload and improves kind of the nervous system functions. But supplemental oxygen, unless their O2 levels are low, I wouldn't see any indicator for that.
Perfect.
I have seen a study out of Italy that was with sleep apnea that showed people with severe sleep apnea that when untreated, it looked like vascular dementia. So of course there's a connection between cognition and getting enough oxygen. And I guess the question I would ask myself is, if it does seem to be helping during exercise, is there something else underlying that's happening where the patient isn't getting enough? oxygen.
Thank you. Dr. Sushila, Dr. Wanapa, anything you want to add? We had 94 participants tonight.
Nice.
Amazing. Oh, I see a question about oral care recommending to brush their teeth.
Yes. So if I understand it correctly, there are research articles to indicate that brushing with a toothbrush versus a tooth swab gets a lot more of that plaque off, reduces bacteria significantly, and we should be letting the patient brush their own teeth because, again, this is tapping into what is automatic for them, procedural, what they've done in their past for a long time. If we're taking that over, we're taking away some of that dignity and independence. So, you know, if they're having trouble using a toothbrush, we can provide like minimal assistance. So hand under hand, perhaps we demonstrate how to use the toothbrush. Again, that scaffolding, right? Just giving the least amount of cues to promote independence.
I often say the brain is like a muscle, so you've got to use it or lose it, and that applies for brushing your teeth. If they want to keep brushing their teeth, they should be doing it themselves for as long as possible.
Yeah. And I guess one thing on that note is we have been reading articles about those lemon glycerin swabs. We've seen it done where people use them as ways to moisturize the mouth, but it does the opposite. So making sure it's toothpaste, mouthwash, things that are meant to remove buildup. Not
Dehydrate.
Dehydrate.
Thank you very much for everything. It is so comprehensive.
You're
Especially the
welcome.
French, too many that I can read for like a whole year. So thank you for everything. Okay. And for Connie, I will talk with Dr. Sushila and the core team and get back to you for the question earlier regards to the visit. Thank you.
Okay, thank you. Thank you so much, everyone.
Thank you. Bye
Have
bye.
a good day.
Have a night
Connie.
night.
Good morning.
Yeah.
Good morning.
Help me to imagine my future.
Sushila.
แล้วสุชิดาบอกว่าฉันจะเป็นdementiaไหม
Bye. Thanks.
All right.
Thank you.
Bye.
Bye.
Oh,